Good morning, everyone. We are going to discuss on sympatholytic agents. Sympatholytics are also called adrenergic antagonists or adrenergic blockers. They have opposite effect of adrenergic drugs. Adrenergic blockers bind the adrenergic receptors and inhibit the action of adrenergic drugs. The adrenergic blockers may block alpha or beta receptors or both. Now coming to the location of action of sympathetic receptors. Sympathetic receptors are alpha receptor and beta receptor. Alpha receptor again alpha 1 and alpha 2 receptor. Alpha 1 again subcategorized into alpha 1A and alpha 1B. Alpha 1A present in the prostatic urethra and eye, whereas alpha 1B present in the blood vessel. Now coming to the alpha 2 receptor. Alpha 2 receptor present in the presynaptic as well as in postsynaptic nerve ending. Presynaptic nerve ending, they act like brake to sympathetic system, whereas postsynaptic nerve ending, alpha 2 receptor present in the blood vessel and in brain. Now coming to the beta blockers. Beta receptor. Beta receptor again subcategorized into three, such as beta 1, beta 2, and beta 3. Beta 1 receptor present in the heart as well as in JG cells. JG cell, that means juxtaglomerular cells present in the kidney. Beta 2 receptor present in the bronchus, gastrointestinal tract, urinary bladder, urethra, uterus, liver, skeletal muscle, and blood vessel. Beta 3 receptor present in the adipose tissue, coronary vessels, and in urinary bladder. Now coming to the sympathetic are alpha adrenergic blocking agents as well as beta adrenergic blocking agents. Now coming to the alpha adrenergic blocking agents, how they act in our body. The important effect of alpha receptor stimulation are alpha 1 receptor mediated vasoconstriction. This drug act through alpha 1 receptor induce vasoconstriction that may induce complications such as asthma. Alpha 2 receptor mediated inhibition of noradrenaline release. The result of alpha blockade by alpha blocker are alpha blockade leading to induce vasodilation and thereby decrease blood pressure. This effect of blood pressure is opposed by the baroreceptor effects, which tend to increase heart rate and cardiac output. Alpha 2 blockade enhances release of noradrenaline, which stimulates beta receptors, where alpha receptors are already blocked. Beta 1 stimulates what results in tachycardia and increased cardiac output. Thus, the main effect of non-selective alpha blockade is hypotension with tachycardia. This is because alpha 2 receptors are blocked and there is no increase in noradrenaline. Selective alpha 1 blockade results in hypotension without significant tachycardia. Whereas selective alpha 2 blockade increases the release of noradrenaline, resulting in hypertension. Because as increase the release of noradrenaline, increase the vasoconstriction. Ultimately, blood pressure will get high. Alpha blockade also results in meiosis as well as nasal toxins. Alpha blockade in the bladder and prostate leads to decreased resistance to the flow of urine. Now coming to the classification of alpha blockers. They are broadly categorized into two. First one is non-selective. Under non-selective will come non-competitive blockers such as phenoxybenzamine, and competitive blockers. Under competitive blockers will come ergot alkaloids such as ergotamine, and others tolazoline, pentolamine, chlorpromazine. Now coming to the second category, selective alpha blocker. Under the selective, alpha 1 blockers will come under alpha 1 blockers, prazosin, terazosin, doxorubicin. Alpha 2 blockers such as Mohammad. These are the drugs under the category of alpha blocker. Now coming to the non-selective alpha 1 blocker such as phenoxybenzamine. This compound binds covalently to alpha receptors, causing irreversible blockage. In IV administration, intravenous administration, blood pressure gradually decreases and associated with tachycardia and increased cardiac output. The action continues for 3 to 4 days. The action of the phenoxybenzamine, it will continues in our body 3 to 4 days. Phenoxybenzamine can be used orally in the treatment of pheochromocytoma. Adverse effect of phenoxybenzamine. The phenoxybenzamine can induce post-arterial hypotension as well as tachycardia. Coming to the selective alpha 1 blockers. The selective alpha 1 blockers, these agents decrease peripheral vascular resistance and lower arterial blood pressure by causing the relaxation of both arterial as well as venous muscles. These drugs, unlike phenoxybenzamine and pentolamine, cause minimal changes in cardiac output. Thus, the hypotensive is more effective than non-selective. Prazosin and its congeners are found to decrease low-density lipoprotein and triglycerides and increase high-density lipoprotein. Prazosin inhibits the post-synaptic alpha 1 adrenoreceptor. This inhibition blocks the vasoconstriction effect of the catecholamine such as epinephrine and norepinephrine in the blood vessel, leading to peripheral blood vessel dilating, resulting decrease. Route of administration of prazosin is oral, preferably prazosin given in oral because it has good effect oral. Metabolism extensively bound to plasma protein and is metabolized in the liver. Half-life of prazosin, its duration of action in our body, 8 to 10 hours. The therapeutic use of alpha adrenergic blocking agents are they're mainly used for the treatment of hypertension. They're used alone or in combination with other antihypertensive drugs. They may improve rather than deteriorate lipid profile and glucose insulin metabolism. They are also used in the treatment of congestive heart failure as other vasodilators. There are various adverse effects of the alpha adrenergic blocking agents, such as dizziness, lack of energy, nasal congestion, headache, grossiness, orthostatic hypotension. This kind of adverse effects may occur in the treatment of alpha adrenergic blocking agents. Now coming to the another drug, ahimbine. Ahimbine is a relatively selective alpha-2 blocker which increases blood pressure and heart rate due to increased noradrenaline release. It causes congestion of genitals because of which it is used to treat psychogenic infertility. It is also claimed to be an aphrodisiac, though the effect is only psychological. The main use of the alpha adrenergic blocking agents are hypertension, pheochromocytoma, congestive cardiac heart failure because of its vasodilator effect, benign prostatic hypertrophy. These are the use of the alpha blocker. Now coming to the beta adrenergic blocking agent. Beta adrenergic blocking agents, they are also called beta blockers. These are the drugs that block the action of catecholamine, such as dopamine, epinephrine, norepinephrine, mediated through the beta receptor. They act through the binding with the beta receptor. Classification of beta blockers, such as non-selective, propranolol, nadolol, timolol, sotalol, cardioselective, such as metoprolol, etanolol, acebutolol, esmolol, partial agonists such as pindolol, oxyprenolol, tartiolol, etc., with additional alpha blocking properties such as levitalol, carbidiolol. Lastly, beta 1 blockers, beta agonists, that is celiprolol. Now coming to the most important and popular drug, propranolol. Propranolol is a competitive antagonist of beta 1 adrenergic receptors in the heart. It is a competitive antagonist of beta 1 adrenergic receptors in the heart. Propranolol selectively blocks the beta 1 receptor in the heart. What will happen? It leads to decrease the force of contraction, which decrease heart rate as well as cardiac output. Results decrease. Now coming to the another mechanism of action of propranolol. Propranolol inhibits vasomotor conduction, which decreases the sympathetic discharge, which causes vasodilation. Once vasodilation occurs, ultimately going to happen with this blood pressure. Now coming to the mechanism 3, propranolol selectively blocks the beta 1 receptor in kidney. It will selectively block the beta 1 receptor in kidney, which decreases the secretion of renin. What will happen? After that, decrease the effect of renin angiotensin system that leads to cause decreased blood pressure. Coming to the pharmacological action of propranolol, effects of beta blockers, no marked effect on normal heart in subject at rest. In presence of increased sympathetic tone, it will decrease automaticity and prevent to rise the heart rate. Decrease myocardial contractility, cardiac output, and stroke work. Slows atrioventricular conduction. Decrease myocardial oxygen requirement. That is the effect of beta blockers. Now coming to the effect of propranolol in blood vessels. They reduce BP by decreasing cardiac output, decreasing renin levels, decreasing central sympathetic outflow, lastly decreasing noradrenaline release from sympathetic terminal. Ultimately, they will cause the reduced blood pressure. The effect of propranolol in the respiratory tract. Propranolol directly causes the vasoconstriction that may induce asthma. Effect of propranolol in CNS. Propranolol does not have central effect in the central nervous system, but it may sense the behavior. It may induce forgetfulness, nightmares, increased dreaming, suppresses anxiety in short term. Metabolic effect of propranolol. Propranolol blocks lipolysis and subsequent increased free fatty acids. They increase triglycerides level and increase low density lipoprotein or high density lipoprotein ratio. Inhibit glycogenolysis in heart, muscle, liver. No effect on normal blood glucose level, but decrease carbohydrate tolerance by decreasing insulin release. Skeletal muscle, effect on skeletal muscle, inhibit tremors, propranolol inhibits tremor. Also, they decrease exercise capacity. The effect of propranolol in eye. Propranolol can decrease the secretion of aqueous humor. Effect in the uterus. This drug may induce the relaxation of the uterus. Now coming to the pharmacokinetics of the propranolol. Propranolol almost completely absorbed after oral administration because this drug, so that this drug is having good effect in oral administration. They have low bioavailability. They undergo high first metabolism in the liver, and they are highly lipophilic. Metabolism depends on hepatic blood flow. Chronic use of propranolol decreases hepatic blood flow. If we use the since long-term propranolol, it may decrease the hepatic blood flow. Bioavailability and half-life increased by 30% on repeated administration of propranolol. Food decreases first metabolism of propranolol. Cerebral metabolism at higher dose. Approximately 90% of propranolol is protein bound in plasma. Volume of distribution, the volume of distribution of propranolol is approximately 4 liter per kg. There are various adverse effects may arise after the treatment of propranolol, such as bradycardia, that means decreased heart rate, COPD, that means chronic obstructive pulmonary disease, bronchial asthma, impairment of carbohydrate tolerance in the pre-diabetic patients. It may increase triglycerides and low density lipoprotein and high density lipoprotein ratio. This drug may also induce angina, tiredness, as well as cold hands and feet. The use of the beta blockers, including propranolol, they may use for the treatment of hypertension, angina pectoris, myocardial infarction, cardiac arrhythmias, and another such as pheochromocytoma, thyrotoxicosis, migraine angina, glaucoma, portal hypertension. In this such kind of complications, we can use beta blockers for their treatment. These are such beta blockers I have mentioned here, their doses as well as their time. Propranolol 80 to 240 mg given for 6 to 12 hours. Metoprolol 100 to 200 mg BD. BD means 2 times in a day. Atenolol 25 to 100 mg daily. Timolol 10 to 60 mg daily. Indolol 10 to 45 mg hourly. Lebitalol 200 to 600 mg BD. And bisoprolol 5 to 10 mg. Thank you.